Hello, and welcome to the Terminology Leading Practice stream of the SNOMED CT Expo 2024. Special thank you to B2I for sponsoring this stream. I am Susie Roy, the Customer Relations and Collaboration Specialist and Research Specialist at SNOMED International, and I'll be moderating today's session. As usual, all questions will be answered at the conclusion of today's presentation, and those who are online, thank you for attending. Please use the Q&A button at the bottom of your screen, and we'll be sure to answer those at the end of the presentation. So now, I'm very, very pleased to introduce Dr. Ismat Binti Sulaiman from the Malaysian Ministry of Health, who will present Connecting Patients with Healthcare Providers with SNOMED CT-enabled Personal Health Records in Malaysia, a concept paper. Dr. Ismat, please.
Thank you, Susie. Hi, everyone. Thank you for being here this late in the day. Right. Okay. Well, this is actually a conceptual paper, very high level still. But I was thinking that I could use this venue to actually gather feedback from all of you, from your experiences. So bear with me. Please do connect with me on LinkedIn, that perhaps maybe later you have ideas and questions that you want to share. We can discuss this further. All right. Okay, so I'm going to break this down into three. First, I'm going to just have a recap so that we can have the same vocabulary on what a personal health record is. And then the idea of leveraging existing data infrastructure and standards, one at least available in Malaysia. And the thought process of going into the concept and how to buy in engagement or the usage of personal health record, both from the public and private sector. We can open discussion there. So I think my talk would be a bit short. Okay, so personal health record. If you look at the ISO, it's very general. Definition is system for recording, retrieving, and manipulating information. But if you look further down, I mean, that's basically almost the same as EHR. And if you look at the paper, it actually provides a continuum, like from one end to another. From one end, or from here top to bottom, from one end, you've got personal health record that is totally individually controlled. And I think there has been attempt to do that. I mean, Google have tried to attempt to create their own personal health record where, people would key in the data information from that end. And then on the other end of the spectrum is the electronic health record, which is very provider-centric, right? All the information and what data is being collected is actually determined by the provider. But usually when we look at the personal health record now that I've seen at least is between that spectrum, right? Between that two ends. So yes, sometimes the personal health record are being provided or being designed by the healthcare provider with the intention of the individual to control it or to use it, right? So how much is that push and pull from both sides, and who determines what is in is very much varies, I think, from one personal health record system to another, right? So this is where actually I want to discuss about, because when it comes to providing personal health record in Malaysia, in our country, in Malaysia, I will share with you that the landscape for Malaysian healthcare sector is dichotomous. That means 70% of our citizens seek care or seek healthcare in the public sector, but 30% still goes to the private sector. And in fact, more than 40, even 45% goes to the private GP, right? So if we don't capture this information at a national level, we are missing a big chunk of that, our healthcare or the status of our citizens, the health of our citizens. So I was thinking about what we have right now. In Malaysia, we have a personal health record called Record Saya. Saya means record, MY. So MY is actually also the two-letter acronym for Malaysia. So usually you will see this my record, Malaysian Health Data Warehouse, my HW. So record saya is actually my record by the Ministry of Health. And this is actually developed for that purpose to have that sharing of information between the provider and the people that we take care of. But this is still within the public sector. And in fact, this is only implemented in one of the states. So Malaysia has about 14 states. One of the state that covers 7 hospitals, 42 clinics, and 11 dental clinics, all in the public sector. We haven't even talked about, the private sector. So in this sense, that record. There you go. Maybe I should need to push it. Yeah, a bit harder. Okay. It does record about the health events, allergies, family history, comorbidities, certain medications, laboratory result. Some of that information, recently they have included about the blood donation drive. So not only they tell where are the blood donation is, but also what is the status of the blood, the blood type of the patients and when it was being done. There you can also that is from the provider side, but the patient also, they can also record their own self-observed or administrative test, such as if they take a home blood pressure, pulse rate, pulse oximetry, and glucometer. The pulse oximetry is actually was very useful during the COVID when they detect COVID, so they want to monitor before the ambulance being called. I think one here, glucometer, glucometer. So if they are prescribed to monitor their glucometer, like for example, every day and so forth, then they can input it here as well. On the personal basis, they are the citizen can also, or the patient can also assess their own health assessment based on common questionnaires. So for example, if they are substance abuse or mental health, alcohol status, so it's not really open to everybody, it's their own record and how they feel about it and whether they are ready to seek healthcare and help, right? And lastly, okay. Lastly is the additional features. So this is, for example, if you want to book appointment, you have the doctors themselves. They want a virtual consultation, some billings history, and to find out where are the nearest facility. That is also provided. So one is where they can access this through mobile, but also they can access this through the portal. So this is patient portal. There is another portal just for the provider. Right? So what's the missing link? I mean, it looks good. It looks good, but there's always challenges, right? So what is the missing link? One, I feel why this hasn't been widespread is actually the connectivity. I didn't put it here, but this is a personal story that actually got me thinking about this concept. I was engaging with the private sector, talking about interoperability, and one of the questions, talking about implementation of IT in healthcare. So it's interesting that one person from the private sector asked all of us, when we talk about interoperability or data sharing, the person said, do you really think the private sector wants to share data? I know, I mean, as a doctor and as a public sector, that's what we want, right? That's what we've been telling people, is how good it is. I mean, even during this whole week, the talk about interoperability saves lives. I mean, that's a great motto to go by. But I mean, coming from the notion coming from the private sector, do they really want to share data? And what is their incentive? Because I can understand, when they say that, I can understand that point of view, because, I mean, if I want to, if I share this data with somebody else, I mean, the patient might not come back to me. they're talking about, I mean, the private sector, they're talking about, monetary incentive. So if I want to share this data to somebody else, will the patient come back to me? Will be my patient anymore? So that sort of spark this idea in the concept that I want to share with you today. And I'd love to hear your opinion in that matter. So the connectivity, I think we all need to, accept it. The notion there are thoughts about that in outside, even though we are being altruistic and taking care of patients. Right. So I can see the missing link here. One is the public and private sector connection. Also, when you look at what we have now, actually we don't have a lot of connection with our allied healthcare personnel. We talk a lot about the hospitals and the clinics, but even within the hospitals, sometimes we missed out the allied health, those therapists, your occupational therapists. I mean, now today we just talk about getting in the nursing as part of SNOMED CT, right? So those are also missing points. And current limitation, Record Saya has been implemented in a single state, like I said before, and only the blood donation module has been implemented worldwide, nationwide, sorry. And I can see here the driving factor is still the healthcare provider and not the patients themselves. So what I'm trying to suggest here is maybe the push factor for interoperability are the patients. But we cannot talk we cannot talk using, SNOMED CT, what is terminology. They will not understand it. So we have to bring it down in the language that they will understand. Right. Okay. So to do that, I was also thinking about what are the infrastructure that is already available in Malaysia. And one of that is the Malaysian Health Data Warehouse. So again, this system was developed in 2015, ran in 2016. Basically, it has a long history. We collect data. I mean, I'm sure in your country as well, we collect information about the patient, a summary of the patient, usually the visits, right? Within that visit is the patient demography, their diagnosis, their procedure that has been done. And additionally, if you have a very good reporting system, you probably collect information about medications and other stuff as well. So in this system is called, oh, sorry. Oh, no. Okay. Okay. So it collects visit and encounter information from the inpatient services, hospital outpatient services, and our hospital outpatient actually includes emergency, the general clinic, and the specialist clinic. Also the PAC. PAC is where the pregnancy. And then there's clinic outpatient services and also ancillary services. Ancillary services, we have 10 right now, if I'm not mistaken. That includes occupational therapy, our radiotherapy, and so forth. So our ancillary services. And that summary actually goes into the Malaysian Health Data Warehouse, either through integration. So if the system, if the facility already have an information system, it will flow. I will try to connect it automatically by pulling the data. But if the facility doesn't have that system, then they can key in through a web-based system. And it goes into my health data warehouse for reporting. So basically, when I talk about leveraging means that since the personal health record really is about sharing that summary, not every little detail in the electronic health record, we can actually, that data is already in Malaysian Health Data Warehouse. So it's a matter of working out the flow, how to push the data into the personal health record. All right. So the proposal. So if you look at the picture on the left side, yeah, on the left side. So No, on the right side, on your right side, sorry. On your right side, in the Malaysian Health Data Warehouse, since 30th June, we have about 102 million visits, about 25 million unique VPI, that means the Virtual Patient Index. I just want to remind you, Malaysia has about 30 to 34 million citizens. So basically, we are almost covering all the patients in Malaysia. And that covers all the different types of facilities, private hospitals, and the university and defense hospital. So the idea is actually to really propose a patient-centered design in the conceptual framework, where the individuals are the one who are empowered to show and share their health data with authorized healthcare providers. So basically what it means that if the patient wants to go anywhere, they are the one who will ask, why isn't my GP sharing data into my platform, right? So they are the people who push it. If I want to go to the hospitals, I want to make sure my GP also share that data to the post-hospital IC. So it's not just about always the top down bottom of government to the people on the ground, but also probably it's both ways, right? Both ways to push that interoperability saves life agenda. And individuals are encouraged data sharing and integrated platform, and to support, of course, individual safety and continuity of care. And I think maybe that is the language that we need to send to people, that if you do use this platform, you want to take care of your continuity of care. I mean, me as an adult, as I'm 40 years old now. So 40 is a magic age, I feel, because you have to take care of the small children, but you also have to take care of your elderly, right? You have to take care of your own personal record, but also your children and also your parents. Having that information is actually vital. So perhaps if you talk about business perspective, that's the target group that you want to target if you want to go down this path, right? So that is the proposal. Again, like I said, starts with the people. The people will engage and kind of like asking all these different facilities, private healthcare facility or public healthcare facilities, whether it's public or private sector, to actually go into the send in the data to that personal health record. And how do they send in that personal health record? Is of course by submitting those data into a centralized system. So of course, here you can see the benefit is, of course, to the patient, but also once you have that data centralized in the government, then you can actually go towards that big data analytics. And even before big data analytics, you would then have the status of Malaysia healthcare as a whole, rather than that 70% only and missing out that 30%. So that's the idea. And of course, when it comes to interface, we can always play this around. It can always be improved. But again, I think when it comes to how to make this faster to be implemented, we already see what IPS, International Patient Summary, can do using HR7 and SNOMED CT. And I hope I can hear Susie's talk after this. It will be very interesting to hear from her standpoint. Buy-in from the public and private sector. Of course, we probably, the government have to initiate it first, provide the platform, and then get buy-in from the patients rather than get buy-ins from the healthcare facilities. Here, the patient is the driving factor. And also, we probably need to do publishing campaigning. Although nowadays, I don't know how to campaign in the TV, because we used to watch TV and there's advertisement and we can always slot in, you know, government agendas. Now they only watch Netflix. So probably have to find ways to do that as well. And then there's always potential for predictive analytics once we have that data. So imagine that you can also use this to prevent hospital admissions. For example, so if you use the personal health record to monitor your daily conditions, and the patients start to record, highish blood pressure, probably heart rate of different varying heart rate, and even probably some symptoms of breathlessness and so forth. So you probably want to even predict and propose to the patient that maybe you should go to clinic before you go to the hospitals, before going to the emergency room. And you can even predict to, for example, set an appointment early, and even allocate or alert the private GPs who are really seeing the patient one-to-one to give advice, and that's so forth. So there's a lot of potential in predictive as well as prescriptive analytics. So that's my last slide. I would love to hear if you have implemented personal health record, or if you have experienced it. I do want to hear what are your challenges. If you haven't, maybe what is your deterring factor, and what do you think what would work well, and what would you have differently if you have implemented it or have you seen it, and perhaps how would you best utilize optimize SNOMED CT in the personal health record. So I'm asking the question before people ask me questions. Yeah, that would be from me. Thank you.
Thank you so much, Dr. Ismat. And we'll take questions from the audience in a second, and also online. Go ahead and place your questions in the Q&A. I'm actually going to jump in, moderators' privileges here, and then I promise to open it up. This was absolutely excellent. Thank you so much for sharing this, Dr. Ismat. Of course, having being lucky to listen to you and many of your colleagues over the years, I know that the elegance and the technical specifications that have been implemented already across Malaysia. And I'm just wondering, you're talking about pulling in the IPS in this situation and utilizing HL7 Fire and SNOMED, and those are standards that I know that you already utilize. Have you done any sort of analysis on some of the data that's already collected within your Malaysian record with the current IPS, both recommended and required elements?
So I think we use the IPS for those people who goes for Hajj pilgrimage. I think I shared that with you, some of you in the member forum, but that's very new. We even though we know that there's about 30,000 goes every year, so we only implemented it this year. We don't know actually how much are actually using it. Right? So what kind of data is inside? So I think it's too early to tell. We do need to study it further, and perhaps that study could really help us in designing the idea behind this.
Yeah, because then you wouldn't have to start from ground zero. So
Correct.
thank you. I'm sorry. That was my own personal, that wasn't even a question that we had talked about sharing beforehand. So I threw that one at you. Now I'll open it up to the floor, and I think you were first. So please go ahead.
I'm Dr. Lee again, Taiwan. I'm so appreciative about. Eventually I found the same people who have the same problem as you in Asia, and let me answer to my observation about why GPO don't like to share their own data with their colleagues, and because Taiwan has forced compulsory upload all the laboratory data and a prescription under the national insurance coverage. We have compulsory upload to the cloud. So upon 24 hours, we will with the identification card of the patient itself, we can take the most recent year, but it's also about 2 years lab data from the other side, from the other hospital or the clinics. And so it is a compulsory policy. And so it is very interesting to observe what's the attitude of the GPS or the other clinician, no matter it's a hospital or the primary care setting. I think what my observation is, yes, before the compulsory upload, we think, and the clinician will worry about their privacy or their primitive way of treatment will be explored. So they lost their competency. But actually, after the compulsory maneuver, now I think the majority becoming the minority. And I think it's matter with highly specialized medicine field in medicine, especially in hospital. So we have bear the habit to share the knowledge and the data of each other. And so, but yes, the elderly, and especially in primary care setting, they still bear the mind not to lose their property, their secret of treatment to the other people. But it will be the myth, and it will be disappear very fast, especially over the internet age. So the first, and the second is the question is you talk about the warehouse of the health data. What kind of data was inputted in? Because in Taiwan, or because of the national insurance system, we are compulsory because it's about payment. So all the diagnosis and the treatment, including prescription and laboratory examination, was compulsory upload. So, but I don't think it's helpful, but I don't think it's the whole thing. So I was just curious about what your warehouse, the content of it is.
Sure. So for right now, the content is, I would say, even connecting or pushing the data from the electronic medical record to the data warehouse. For inpatient example, we have about diagnosis, procedures, and medications, basically. So we haven't even pulled data about laboratory, about radiology reporting, and so forth. So it's very basic, but I think that's for inpatient. For outpatient, it's a bit more detailed because there's so many modules. Like for example, for teenagers module, and there's women health module, and so forth. So, but basically, it's very high level. I think a lot of our information is mainly about diagnosis and procedures and medications. I think, and when I look back, by personal observation, personal experience, usually these are the things that you carry to everywhere, and sometimes you forget also. That's why you need to carry that information. Yeah, but all the other things in the what we already have in the record saya, I think that's additional items that can be enriched further.
We actually are out of time, unfortunately, but that was excellent. And if we can please give Ismat one more round of applause.